Good morning. I'd like to call the meeting to order. The Minnesota Senate Health and Human Services Finance and Policy Committee. It's Wednesday, March 12th, 2025, and we do have a quorum present. Our first item on the agenda is to get a forecast overview. First, we will be hearing from the Minnesota Department of Human Services. And we have Elise Bailey here to present. And good morning and welcome to the committee, and please state your name for the record and begin.
Good morning, Chair Wickman and members. I am Elise Bailey. I'm the Budget Director at the Department of Human Services. I was planning to be joined by our CFO, but he unfortunately couldn't make it this morning, or may be joining later. So with that, I'll just briefly go over. So I have a few slides at the beginning here on what the updated kind of total budget is for DHS. After the February forecast in fiscal year 2026, about 55% of our funding will be from the federal government. That's just over $14 billion. And 37% of our funding will be from the general fund, so about $9.5 billion. The remaining funding that we have at the agency is through the Healthcare Access Fund and a few other funding sources, such as the Opioid Epidemic Response Fund and other smaller funding streams. We, of course, serve a lot of folks across the state with those funding and programs, about 45% of kids, 29% of adults, 17% of older adults, and 28% of people with disabilities with that funding. With the February forecast, this slide is a slide I've shown a few weeks ago when we released the governor's budget or when we did the DHS 101. And our percentages of how we spend that funding hasn't changed with the February forecast. So about 89% of that funding is towards medical assistance. 6% is towards other forecasted programs that we'll go over today as well. And then 3% is towards grants and 2% is towards central office operations. And those grants and operations funding won't be part of this presentation because they aren't forecasted programs. So diving into the February forecast, in fiscal year 2026, under the medical assistance program, we'll have about $9.6 billion projected spending in state funding. So excluding the federal funds that we receive through that program, almost $10 billion in state funding will go towards the medical assistance program. Just over half of that is in long-term care facilities, waivers, and home care. $2.6 billion or 27% will be spent on the basic care services for people with disabilities and older adults. $1.8 billion or 19% on the basic care services for children and families. And then just $295 million or 3% of the state funding will be on adults without kids basic care. This slide is a slide I showed before as well, and just depicts why those numbers vary so drastically by those different populations, in that the federal match does vary by population. For example, the adults without kids, we currently have a 90% match, making the state funding to serve that population pretty small comparatively. So going into other forecasted programs, we have about $718 million projected in state funding in fiscal year 2026. And I've listed all of those other forecasted programs. I'll point out that the Minnesota Care program, so $104 million in state funding we're projecting in fiscal year 26. We get a lot of federal funding, so that's why that number is so low when you're just looking at state funding. Whereas the Housing Support Program, General Assistance, Minnesota Supplemental Aid, and the Alternative Care Line are all state-only funded programs. Slide 7 goes over the summary of changes in the February forecast. So we're projecting 1.9% change in this current biennium, so the one ending June 30th of this year. That's about $290 million in this biennium. And then going forward, 1.9% next biennium and 1.6% in the planning years. In the Healthcare Access Fund, we're projecting about a 3.3% increase next biennium and then a 3.9% increase in the planning years. Slide 8 just gives a brief snapshot of the total dollar figures for the changes in the February forecast. Now, a reminder, the dollar figures we're showing here are the difference between November's forecast and February's forecast. So they're not the total figures of how much we spend on these programs, but what the difference is between the two forecasted data points. I'll spend the majority of the rest of this presentation focusing on the biggest changes, which are in Medical Assistance Minnesota Care and the Behavioral Health Fund. So the main drivers in this forecast are 4 key areas. We're continuing to see disability waiver spending growth. We're also seeing some changes in the payments for our basic care programs, and that's mainly due to a change in acuity within the managed care program. We're also seeing an increase in the amount of spending that we're doing on weight loss drugs. And then we have one key area in the Behavioral Health Fund where we found a federal coding error where it changed the difference between what was coded as federal funding and what is coded as state funding. Slide 10 goes over just a snapshot of the medical assistance expenditures each year over time, updated for the February forecast. So diving into those key changes, looking at the Minnesota medical assistance disability waivers, we're continuing to see trends in increasing forecasting for this program due to 2 key kind of main drivers in this February forecast. We're seeing an increase in what we're projecting for the inflationary adjustments for the disability waiver rate system. So these are the majority of services under the disability waivers have rates determined by the disability rate system, and they get an inflationary adjustment every other year. That inflationary adjustment is based on changes in Bureau of Labor Statistics codes as well as the CPI. So in this forecast, we're projecting about 1% higher than previously projected for those adjustments. We're also seeing average payment data continue to grow, meaning the total number of units that we're paying claims for under the disability waivers growing, and it's about 1.5% higher than previously forecasted in November. In terms of the people that we're serving on that program, we're seeing a higher recipient growth on the developmental disability waiver, or the DD waiver, particularly around children and youth. And so the forecast is increasing the recipient base by about 1%. The total impact is $35 million in this current biennium, $160 million in the next biennium, and $141 million in the tails. Some other changes in long-term care, we are seeing average payment operating rate increases higher than previous forecasts for nursing homes, as well as increased paid days projections are due to an upturn where we had a more flatter trend previously. It's a pretty small change, however, comparatively, $9 million in next biennium and $11 million in the tails. There's also some implementation changes in this forecast. We're currently undergoing implementation of the Community First Services and Supports Program, CFSS, and this program is transitioning the old PCA program into this new program. One key attribute of this program is that we will be able to pull down a 6% enhanced match from the feds once folks transition over, and it's a rolling transition over the next year. So we're seeing in this forecast there's a slower than previously anticipated transition, and so there's a one-time kind of adjustment for that slower take-up of that enhanced federal match. The legislature also authorized in, I believe, 2023, a state-funded ability for parents and spouses to maintain their caregiver option under PCA. This was something that was allowable under the pandemic, and then once the federal emergency ended, it was not allowable, and so the state ended up creating a state-funded only option until CFSS is up and running, because CFSS is a different federal authority that allows that, and so this is another one-time cost where we're have a state-only funded program until that CFSS program has fully taken effect. Looking at basic care, we have a few driving factors in the increased payments here. When it comes to fee-for-service, we are finding higher than expected average payments as part of the transition, kind of from declining payments during the pandemic. Now we're in a post-pandemic era, and we're seeing an uptick slightly in the fee-for-service payments. That's $65 million in this biennium, $75 million in the next, and in the planning years, $98 million for that increase. Managed care, we've had to, since the November forecast, we've had to update our managed care contracts due to an adjustment on acuity for the remaining population on the MA program. So as a reminder, of course, during the pandemic, folks were staying on the program in order for us to maintain this enhanced federal match. And then once the federal emergency ended, we started re-enrolling folks through the traditional means. That process has been completed, and this adjustment, it just adjusts for the new population that we're serving has a different level of acuity than the larger population that we served during the pandemic. This is a one-time cost because we already had assumed some increases in acuity in the planning years and next biennium. So this was a one-time adjustment with our managed care plans of about $31 million in this biennium. In this forecast, we're also seeing some increased costs for weight loss drugs. So weight loss drugs were added to medical assistance in fiscal year 2022. At that time, I believe we had only 2 available drugs on the market, and since then there has been an increase in FDA approval of new drugs. And we're seeing the increase in the number of drugs available as well as increase in the number of people receiving the weight loss drugs. We do have prior authorization requirements and quantity limits on this, on the use of weight loss drugs. However, we are seeing, even with that, a significant increase in the use of the drugs. So in this forecast, we're updating our managed care contracts to account for the increased expenditures in this area. $11.7 million in this biennium, $78.7 in next biennium, and in the, hi, welcome, $87.6 million in the planning years. You arrived just in time. This is your slide.
Thank you, Madam Chair.
Welcome to the committee.
Members.
Mr. Greenman, please state your name for the record, and then you can begin.
Thank you, Madam Chair, members of the committee. My name is Dave Greenman. I'm the CFO of the Department of Human Services, and I own a 13-year-old car, and it just doesn't always want to cooperate. So I apologize for being late to this hearing. I'm going to talk about the impact of the DHS expenditures on the forecast related to the Behavioral Health Fund. In December of 2024, DHS staff identified an error in the funding source for services provided by a small number of residential substance use disorder providers dating back to 2015. It was discovered that the claims that were submitted, or that the claims were ineligible for federal funding because the providers, these particular providers, meet the federal status of institutions for mental disease. And due to the fact that they are considered what is known as IMDs, the services are covered, but they are required to be paid for with state dollars. The payments were for, the payments were for services that were actually provided. The providers were paid at the correct rate, but the error was with what the funding source was used. When we discovered the error, DHS contacted the OLA, as we're required to do, and MMB as well as CMS, since they were the funding source that we were using. We immediately took steps to retroactively change the funding, or we took steps to change the funding code so that going forward we would be paying with state dollars. And what you were seeing reflected in the forecast is a couple items. One is the $113 million, which is the cost of for the last 10 years of the services or the claims for these providers that had been paid with federal dollars that actually should have always been paid with state dollars. So we're having to go back and retroactively adjust the payment source. And what that will be reflected in the Behavioral Health Fund as an increase in state spending in fiscal year 25. There will be a corresponding reduction in federal funding or federal spending in the Behavioral Health Fund because of the fact that we're replacing the federal funds with state dollars. This was an error that obviously should not have occurred. We're required to pay for these services with state dollars, but we should have been paying for them all along and not doing it now. One thing to know is that these particular IMDs are operated by tribal governments. They may voluntarily choose to enroll in a waiver operated by the federal government that other IMDs are currently included in the state are currently enrolled in, which does provide a federal match. So we have been meeting with these particular IMDs, and the tribal leaders, DHS leaders, have met with the tribal leaders and are going to assist them if they choose to enroll in the waiver. The forecast at this point going forward assumes that there will be state funding for these particular IMDs for a period of time, but that over the next 2.5 years, they will eventually enroll in the waiver, and they'll be, once again, 100% state funded. This is one of the things we have to do in a forecast, is we have to try to anticipate what we think is going to happen. We know that these IMDs are eligible to be in the waiver, and so we are assuming that over time they would get the same payment rate if they're in the waiver. So we're going to just be working with them in case in case they want to voluntarily enroll. So what you're seeing in the forecast in this case is $113 million in one-time expenditures in fiscal year 25. You're also seeing another $12 million in fiscal year 25, which is for the payments going forward for these IMDs, and another $19 million in fiscal years 26, 27, as they transition onto the waiver. That's our assumption.
Sorry, Senator Abler.
Well, thanks, and I appreciate the explanation. I didn't know it was 10 years, so that's, I didn't know it was 10 years, like, wow. And so, just really briefly, I know you're trying to get through the presentation, but, with the waivers and all that, the letter that we sent asked for extreme flexibility. The governor of Oklahoma wrote a letter suggesting flexibility. I thought, well, that fellow was brilliant. It was a similar letter to what we wrote. But it seems to me, since everybody's broke, we are and the feds, and so $36 trillion is a lot of money and whatever is going to happen, that the more flexibility we can extract out of there, in my mind, actually just leaving us alone to run it how we want, that would be if I were king. I'm not. But it might be a good time just to continue to ask for more and more flexibility. And even this idea about IMDs and all that, it really should be in the state's hands to decide what they think is a careful, thoughtful way to care for individuals. If you can get a waiver, then clearly it wasn't harmful. And just like that. So, we have 4 units. Maybe we used to have 8s, and people thought that was all right, but somehow that was not okay. And it only served to increase costs, and now we're depriving people of services potentially in the different plans to balance the budget. So just an encouragement to all of us, I think. Minnesota cares about people with disabilities and substance and all that, and so I just hope I'll just keep helping you with that. So thank you, Madam Chair.
Senator Utke, did you have a particular question about this slide since we stopped, or do you want to wait and just hear the rest of the presentation and then?
I do about this slide, but I can wait till we're done, and then we'll
Okay.
go back to this slide.
Okay. If you want to proceed, thank you.
The next slide looks at the impact of Minnesota Care expenditures on the February forecast. There's 2 impacts, and I think Ms. Bailey alluded to both of these impacts in the Medicaid program previously. The first is weight loss drugs, where Minnesota Care also covers weight loss drugs in the same manner that Medicaid does, and we are seeing the same increase in expenditures for weight loss drugs covered in the Minnesota Care Program. The other impact is updated eligibility showing some higher than expected enrollment, which we're assuming in both cases for the weight loss drugs and the higher enrollment, we're assuming that this is in the base, that this is going to be more or less a permanent increase, which is why you'll see the numbers. We're showing a healthcare access fund increase of about $68 million in 26-27 and about $77 million in 28-29, with about 75% of it due to the weight loss drugs. I think one thing to note about, on this next slide, one thing to note about the forecast is it's based on current law. It's based on what we know is in state and federal law at this time. But one thing we do want to make sure to mention, and I think everybody's aware of it, is there is a lot of uncertainty right now related to what may or may not happen at the federal level regarding the Medicaid program. Given the outsized impact that Medicaid has on the state, in terms of providing coverage for 1.2 million people, for payments to providers, and the way those payments go out throughout the state, we need to be paying close attention and assessing the actions at the federal level and trying to anticipate what may happen, because depending on what happens, we may need to respond as a state if there are cuts to Medicaid. I think one of the issues that we've seen is the House budget resolution that directs the committee overseeing Medicaid to cut $880 billion over 10 years. Obviously, we don't know what the legislative proposals would look like that are related to that. We do know that most of that would have to come from Medicaid unless it's from Medicare. But a cut that size in the Medicaid spending would be around a 10 to 12% reduction in the federal outlay for Medicaid. That translates, if that's proportionally passed along to states, which it may or may not be, that would be around a $1.4 billion to $1.6 billion impact in Minnesota per year at the beginning, and it would increase over time. Obviously, the impact of any federal action on Minnesota would depend on what that action is, what particular legislation they would be used. There are other areas of uncertainty right now with regard to the state budget related to potential federal shutdown that hopefully is headed towards a resolution for a period of time at least. And also, I think that I'll just leave it at that. And we'll open it up for questions.
All right, members, questions. Senator Radke.
Thank you, Madam Chair. And I've got a few different things here, but we'll just back up because that was only a page ago with page 15 when we were talking about the IMD waivers, et cetera. As I understood that last week was, and actually it started with the question, were the IMDs offered in 2015 when this all started to get on the federal waiver, and they elected not to? Or what do you know about that process back then that got us in today's predicament?
Mr. Greenman.
Madam Chair, Senator Radke, that's a great question. There's a lot of history behind how we pay for IMDs, and there's been a lot of changes over the last 10 years. Historically, IMDs have always been, the federal government, IMDs are a designation put on residential treatment programs of 16 or more beds, or more than 16 beds, I should say. And historically, the federal government has never provided federal money for those. Starting at some point, I think around 2017, 2018, the federal government did provide a waiver with what's known as the SUD waiver that would allow states to, states that pass the law to enact the waiver, for IMDs in that state that meet certain standards to enroll and start receiving a federal match. And that was really the first time there was an opportunity to get a federal match on IMD services. And this was, like I said, in Minnesota, I think it started in fiscal year 2020 with a change in law. At that point, it was voluntary for IMDs in Minnesota to be part of the waiver and get a federal match. And the standards for qualifying for the waiver were pretty high, and I think a heavy lift for a lot of the IMDs. So there wasn't a lot of enrollment in the waiver. It was fairly gradual over time. In January of 2024, all IMDs were required to enroll in the waiver and to meet the standards obviously for being in the waiver. The exception was that tribal governments, while they are required to meet the standards for being in the waiver, it is voluntary for them to enroll. So there's some history there around when it first became there was first an opportunity to be in the waiver, and then what standards need to be met to be in the waiver. I hope that makes some sense. It's a bit confusing.
Senator Rudke.
Thank you, Madam Chair. Yeah, I followed what you were, the timeline there. Of the amount that basically is due, that we're going to have to pay back to the federal government, how much of that wouldn't be there, or we wouldn't have that obligation if those enrollments were done on time? Would it all go away, a portion of it? Where would we land on this?
Mr. Greenman.
And I should clarify when I say on time, at the first that the enrollment was available.
Madam
Mr.
Chair,
Greenman.
Senator Wickland, it's difficult to know because it's difficult to know when and if those particular IMDs changed their service model to meet the standards to be in the waiver. So so it's not clear when like I said, when the waiver was first put in place in 2020, most facilities did not meet the standards because it was a heavy lift to get the services upgraded to that level. It's not clear when these particular 7 IMDs that we were talking about, when they met that standard, and even if they did meet that standard, they still have not chosen to enroll. So it's a hard question to answer. At this point, none of the costs are eligible looking back for federal funding because they were never enrolled in the waiver.
Right.
Yeah.
Senator Rudke.
Okay. Thank you, Madam Chair. So as of today, if they were enrolled going forward, we wouldn't have any of these costs. Now, and this can go to either one of you or, you guys are the messengers today. But what are we doing to make sure that they're enrolled right now and not letting this go on? Because we shouldn't be paying this amount of money. I mean, when all it takes is to enroll.
Madam Chair, Senator.
Mr. Greenman.
Madam Chair, Senator Utke, we have, once we discovered the error, we have started to meet with the tribal leaders. DHS leaders have started to meet with them to talk to them about what the impact is of the situation that we're in, where we're having to switch federal funds for state funds going forward, and also to talk to them about the waiver and being enrolled in the waiver and what that might mean as well, and offering our assistance and support should they choose to enroll. But as I mentioned, under state law, they are not required to enroll. It is voluntary for the tribal IMDs. So we're actively working with them. And like I said, the forecast assumes that they will eventually enroll, but we don't expect it to be immediate.
Senator Rudke.
Thank you, Madam Chair. I guess as I listen to that, I would highly encourage that we make that a priority, and I think our taxpayers that are going to be paying this $156 million would also say we want it done right now, because there's really no excuse for this amount of money that we're paying out, and I would hope that that rises to the up to the top of the priority list, because we do need to address it. Let me just I guess that's pretty good for right now. Most of my stuff was around that, the error there in the coding, and it's, I guess the comment about the coding, and again, you guys are the messengers this morning, but it seems like we hear about this quite frequently. We had an error, we have this or that, and it's not that we're just a few $1,000s. We're talking many, many millions each time. And I guess internally, and that's somebody else's position to answer that, but what are we doing to eliminate these type of errors? So I know that you maybe need to, that's something that comes from the core operation, but that's a concern as I hear it and others hear it is, how do we, there's always going to be something, but it seems like this is a pretty constant message we're getting, and people are looking for change. So thank you.
Any comments? Mr. Greenman?
Madam Chair, Senator Rutke, I think you raise a great point. I'll just keep it really brief because I know you need to move on, but we would be happy to talk to you about the work that we're doing at the department right now to look at doing financial, improving financial controls is a continuous process. It's not a destination in a sense. And we're always looking to improve the way that we do our work. These are not, we don't want to come in front of you with these kinds of situations. And ultimately, I'm accountable for that and making sure that we are putting the steps in place that we avoid this. I would be happy to talk to you more about that sometime.
Senator.
Thank you. Thank you, Madam Chair.
Okay. Any other member questions about this presentation? I don't see any right now. I appreciate the links at the back of your presentation to more details. Members, if you have specific, if you want more specific information, there's links to the forecast and spending data and other details that might fill in some more information. So I appreciate your bringing this forward to us today, and thank you for your time.
Thank you.
Next, we'll move on to a forecast overview from the Minnesota Department of Children, Youth, and Families. And we have Ashley Reisenauer here. Welcome to the committee, and I'll let you get your presentation connected.
Is that going to connect? I don't think. Connected.
Great. Welcome to the committee, and please state your name for the record and begin.
Thanks, Chair Committee. I'm Ashley Reisenauer. I'm the Chief Financial Officer for the Department of Children, Youth, and Families. And I'm joined by Marina Valeria, who's the Budget Director for the DCYF. Thanks for inviting us today. We're going to give a brief overview of the February 2025 updates for forecast programs. So the forecast programs that we're talking about today are ones in which eligibility and benefit levels are established in statute, and the spending projections are updated twice a year in November and February. The Department of Children, Youth, and Families operates 5 of these forecasted programs, 3 of which transferred from the Department of Human Services, the Minnesota Family Investment Program, Child Care Assistance Program, and North Star. The bottom 2 transferred from the Department of Education. They're the Early Childhood Health and Developmental Screening, as well as Early Childhood Family Education. So as I mentioned, we'll talk through today the forecast projections, which are based on historical program trends in enrollment and spending, and account for implementation of current law policies. It's important to note that the projections we're talking about are based on current law, so they don't include any changes being contemplated at state or federal levels. Today, most of our presentation is going to focus on changes to general fund spending for these programs. Three of them, MFIP, Child Care Assistance, and North Star, also have a federal share, which you'll see on the following slides. This slide shows the projected general fund spending for each of the programs, as well as the change relative to the November forecast. So the first two columns show the 24-25 biennium, the current one that we're in. The next two represent the upcoming 26-27 biennium. And then the last includes the planning years, the 28-29 biennium. You can see that in the upcoming 26-27 biennium, we're projecting $781 million in state spending for these 5 programs. That's a $16.8 million decrease, or about 2.2% less than in the November forecast. Overall, there's a slight decrease in projected spending across all 3 biennia, primarily just driven by updated data on trends in the program. So the Minnesota Family Investment Program provides cash and food assistance to low-income families with children. It's a vital program. It serves over 62,000 people each month. The graph shows the trends over time with both the federal and state shares. Today, we're really just focused on the state share portion and changes in this forecast. So during the forecast horizon, the state general fund is projected to increase from $84 million in fiscal year 2025 to $135 million in 2029. Compared to the November forecast, projected general fund spending on this program is about $200,000 lower, or 0.1%, in the 26-27 biennium, and about $2 million higher, or 1.1% in 28-29. It's a small change. It's primarily driven just by a mix in the state and federal funds based on slight updates to enrollment trends in the program. The Child Care Assistance Program provides child care assistance to MFIP families while they're employed or engaged in other work activities or education as part of their MFIP employment plan. The activity also provides transition year child care assistance for former MFIP families. So in state fiscal year 26, we're expecting to serve over 11,000 children from about 6,300 families across the state. During the forecast horizon, state general fund is projected to increase from about $56 million in 2025 to $175 million in 2029. Compared to the November forecast, the projected general fund spending on the program is about $15.8 million lower, or 6.2% lower, in the 26-27 biennium, and about $1.3 million lower, or 1.7%, in 28-29. The change is primarily driven by slower than expected growth in the projected number of children served in the program. So it doesn't necessarily mean that numbers are declining, just that they're growing somewhat slower than we projected back in November. The North Star Care for Children is designed to help children who are removed from their homes and supports permanency through adoption or transfer of custody to a relative. Financial support is provided to adoptive and foster parents to encourage permanent placement of children in safe homes. The program supports about 18,500 people across Minnesota each month. During the forecast horizon, the state general fund spending is projected to increase from $104 million in 2025 to $126 million in 2029. Compared to the November forecast, projected general fund spending on the program is about $400,000, or 0.2% lower in both the 26-27 and 28-29 biennia. So again, a small changes, primarily driven then lower than expected numbers of kids in foster care and adoption assistance, which is partially offset by a slight increase in projected kinship assistance recipients. The Early Childhood Family Education, or ECFE, is a program that transferred to DCYF from the Department of Education. It's a community education program for children birth through kindergarten, their parents, and parents who are expecting children. This particular forecast also includes the home visiting portion of the ECFE program. The program is supported with a combination of population-based equalized levy program as well as state general funds. What we're looking at today is just the state general fund portion. During the forecast horizon, the state general fund spending is projected to increase from $38 million in 2025 to about $45 million in 2029. Compared to the November forecast, the general fund spending is about $500,000, or 0.6% lower in 26-27, and $4.5 million, or about 5% higher in the 28-29 biennium. Again, the changes are primarily driven in a reduction in the projected census increases that inform the program, as well as somewhat higher projected increases in the formula allowance due to the CPI. Our last program is also one that transferred from the Department of Education. And I'm going to apologize because I noticed this morning that in your packet, the graph might be incorrect, but we will get you an updated one just in case. The one on the slide is correct. But this is the Early Childhood Health and Developmental Screening provides funding to public school districts to screen enrolled children between the ages of 3 and 5 to identify possible health or developmental concerns and link families to resources. Spending on the program has been really steady at about $4 million a year. There's a slight change compared to the November forecast. Projected spending is about $100,000 or 0.8% higher in 26-27 and about $100,000 or 1.1% lower in 28-29. And the changes are just driven by a slight birth decline and children being screened earlier, closer to age 3 rather than age 5. So that's a summary of the forecast programs at DCYF. There are links to more information if it's helpful, and we're happy to take any questions.
Thank you. Members, do you have any questions about this presentation? I do not see anybody having any questions. The differences are fairly small, and it's pretty hard to attribute them to big change. You don't have big changes to attribute them to. Thank you for the information, and then if you wanted to send us the slide or the chart for that one page, I think the information on the bottom of the slide reflects what's on your slide, but if you want to send us an updated slide for that one, for the screening, that would be helpful. I guess I don't have any other questions right now, and I appreciate your coming to us and presenting this information. Thank you.
Thank you.
Next, we will move to bills on our agenda. Our first bill is Senate File 1385. Senator Dibble. Welcome to the committee, Senator Dibble, and please proceed to present your bill.
Thank you, Madam Chair and members, for the opportunity and the honor of presenting Senate File number 1385. Let me also, I was going to thank my co-authors, but I don't see any here. So I'm sure there will be more soon, or at least I don't have them on my printed version here. So Madam Chair and members, Senate File 1385 is a request to fund HIV and AIDS supportive services and grants administered by the Department of Human Services HIV Supports Division. I'm sorry to bring you the news that nationally we see cases of HIV and AIDS decreasing, but in Minnesota they continue to rise year over year, and you can see some more detail around that in one of the 3 letters that are in your packets that are in support of this proposal. For many years now, I think in excess of 20 years, we've been averaging around 300 new infections of HIV in Minnesota per year. In the last tracking cycle, we report 324 new HIV diagnoses. So just very quickly, by way of summary, does not create a new vision or new services. What we've been experiencing is the rebates from the AIDS Drug Assistance Program, which fund HIV supportive services, which provide critical case management, ensuring people living with HIV have access to medication to suppress viral loads, have stable housing and food, is at a zero balance due to changes around the rebate program and other changes at the federal level. If the state does not invest in maintaining these services, Madam Chair and members, it's not an exaggeration to say that some of our community-based organizations will have to close their doors. Madam Chair, members, we have adopted as a state policy to end HIV and AIDS in Minnesota. We did that a few years ago with a nearly unanimous vote of the entire legislature. I think there was one holdout in either the Senate or the House, I can't remember, but we had nearly unanimous support for striving and aspiring to achieve that outcome, because we know with what we have available to us today by way of medication and prevention and support services, we can bring new infections to zero. But what it takes, of course, is commitment and focus and diligence. We know that if folks are connected to care and are able to take their medication with fidelity, their viral load is suppressed to zero and they become non-infectious. Likewise, access to PrEP and PEP means that they're non-transmissible if they're in fact HIV positive. The magic, of course, is connecting folks to care and keeping them connected to care and overcoming many of the barriers, whether that's food insecurity, housing insecurity, access to chemical dependency and mental health services, social connection, and also having a relationship with a pharmacist and a doctor. So that's what we mean when we say housing and treatment is prevention. We used to think about prevention as something else. Now we know that making sure that lives are stable and secure is HIV and AIDS prevention. And we're just not bending the curve down. Something is amiss. And if we lose this $9 million and have no money to spend, it's just going to become worse and worse. So we have the medication, we have the science, and we need to assure that those who are most vulnerable have what they need for a healthy and stable life. And Madam Chair, just to put a finer point on the crisis that we're in, the Trump administration has paused grants in this area, and at stake, if in fact these pauses turn into full freezes and defunding, will be the full breadth of the Ryan White HIV/AIDS program, which provides people living with HIV access to life-saving treatment and services. The program known as Ending the HIV Epidemic, EHE, and the Minority HIV/AIDS Initiative. Programs designed to provide tailored approaches to care for communities disproportionately impacted. Housing opportunity for people with HIV and AIDS, known as HOPWA. It's been around a long time to provide that housing security, which I just mentioned. You, of course, know about the discussion and the threats to Medicaid presented by Congress. On access to PrEP and other HIV prevention efforts, which is vitally necessary to prevent the HIV epidemic. And we've already seen at the CDC and at SAMHSA, and which provides funding for HIV prevention efforts, mental health services, substance misuse treatment, addressing the opioid crisis, pauses in their funding, and a complete wiping out of all information on their websites pertaining to HIV and AIDS and its care and its treatment and access to information about accessing services. So that's the crisis that we're in. This $9 million would go a long ways towards helping us address that. So that's my presentation of the bill. I'm able to stand for questions, or we have a number of folks. I don't have the list myself of folks who are ready to testify, but there are a number of them.
Yeah, I show 3 testifiers on our list. First, I'll call up Mary McCarthy and Brian Young. Welcome to the committee, and if you could please state your name for the record and begin your testimony.
Good morning, Mary McCarthy. Excuse me. Thank you for the opportunity to be here and speak with you all regarding this important legislation. I work for the Rural AIDS Action Network. I'm the executive director, and our agency happens to serve all of greater Minnesota, which includes many of the suburban areas. Senator Dibble gave you a lot of good background information, but I just wanted to provide a little bit more context in what we're talking about with respect to the people that we serve. In Minnesota, as he said, we've continued to see increases in the number of cases. It's been fairly stable. I've been in this field for over 20 years, and I haven't seen much deviation during that period of time, with the exception of changes in medications and understanding about how we can manage this chronic condition. Obviously, people are not dying at the lengths and the depths that they have in the past, and that's a good thing because we need as many people in our communities as we can. We've seen steady increases, and currently there are almost 10,000 people. I would say by now that we have reached over 10,000 people that are living with HIV in the state of Minnesota. 56% of those people live outside of the Minneapolis and St. Paul metropolitan area, which is, I think, an important fact for you to understand. RAN, which is our agency's acronym, Rural AIDS Action Network, serves approximately 550 people in case management services. At least that's what we did last year. Those numbers continue to rise, and that reflects only about 10% of the people living with HIV in Greater Minnesota. We do have some partner agencies that have additional folks that they work with, so we are seeing a large number of people that are receiving services. And I can tell you, as Senator Dibble referenced, the medications that are available, of those people that we case manage, over 90% of them are virally suppressed, which means they are not able to transmit the disease to anyone else. The importance is identifying those who don't know their status or may not be in care to ensure that they are receiving those services. As I'm sure you understand, folks living outside of the metro area have less access to services and supports. One of the missions that we hold very dear in our hearts is to ensure that people affected by HIV, which means their families and the communities, are knowledgeable about the disease, understand transmission, but more importantly, get caring and compassionate care throughout their condition and support that they need to manage their disease. We do know that all counties in in Minnesota are impacted by HIV. There is at least one person living in every single county of our state. Our agency has represented folks in 60 of those counties in 2024 alone. Throughout the years, we've served people in just about every county. As I'm sure you can imagine, transportation and other things are valued and needed support, particularly for those individuals to get to health care, which often requires them getting specialized treatment in locations that are far away from their home. The supportive services that we provide, including transportation and food supports that are provided by other organizations serving the same population, are crucial and necessary for them to maintain their overall health and obviously continue being successful in their overall health care needs.
Thank you. Or did you have more?
I just wanted to say that the governor's budget does include some funding, but this bill increases that funding just a little bit. And I think Senator Dibble pointed out all of the rationale that makes it really important for us to get this additional funding. He is not being deceiving at all. A lot of us are facing definite shortfalls in the funding that we receive, which means we can serve less people, at least, if you're talking about the cost of care per person. In reality, we're seeing more and more people seeking out services on a daily basis. And with these cuts that are proposed, we don't know how we'll be able to sustain that. And my biggest concern is that the positive outcomes we've seen in people's health will diminish over time when they don't continue to have the care and support that they need through case management and all the other supportive services that we're able to provide. Many of our agencies are really operating on a shoestring. I can tell you that my organization gives back over 90 cents on every dollar that we receive in grant funding to our programs, which means we're a very lean operation and we're struggling just to keep the doors open with general operating expense, but additional cuts in our grant funding will mean that we can serve even less people. So thank you for your time.
Thank you. Welcome to the committee, and please state your name for the record and begin.
Yes, good morning, Madam Chair and members of the committee. My name is Brian Young. So I have the pleasure and the honor of serving both as a housing case manager, and I am also a Minnesotan who myself is living with HIV. I work for Clear Housing, which began in 1987 with just one house and a handful of residents who at that time were living with what was known as AIDS. Fast forward to today, and we've now expanded to serving about 300 Minnesotans each year who are living with HIV by providing a range of supportive housing options, covering everything from independent living to more intensive assisted living with on-site 24/7 care. As a housing case manager, I have again the honor and the pleasure of standing with and supporting about 25 to 27 individuals and families in securing and maintaining stable housing in what we call our scattered site program, which provides portable rental vouchers to our clients. My work is primarily to help folks access and navigate essential resources, which includes not just housing, but also food support, transportation, medical care, and public benefits. In addition to the services that I personally am able to offer, folks often rely on a network of other services and supports to increase their overall stability, improve their health, and maintain their well-being. Need to stock up on food after SNAP benefits run out this month? We'll get you an appointment down at Aliveness Project's Dignified Food Shelf, but we have to call right at 9 in the morning because those spots fill up pretty quickly most of the time. Behind on rent this month because of a family emergency? No problem. We'll contact Every Penny Counts to see if they can provide some rental assistance. Health insurance get cut off suddenly without warning? Okay, hold on. Let's reach out to your medical case manager and the benefits counselors over at Positive Care to see what's going on and if they can help us figure this out. These are just a couple of the essential HIV services that I see clients benefiting from and turning to for support regularly. Day by day, as Senator Dibble mentioned, it seems uncertain what resources or funding will continue to be available for our clients. With many of our clients at the intersections of multiple marginalized identities and experiences, maintaining a commitment to diversity, equity, and inclusiveness has never been something that Clare Housing can opt in or out of. It has always been absolutely fundamental to what we do. And right now, unfortunately, that makes Clare Housing, our fellow HIV service providers, and most importantly, our clients and neighbors across Minnesota vulnerable. All of this comes, again, as Senator Dibble mentioned, amidst the ongoing HIV outbreak in Hennepin and Ramsey counties, where all of my clients live and which continues to disproportionately impact marginalized communities, including intravenous drug users, folks facing unsheltered homelessness, and people of color. 2023 saw the highest number of HIV diagnoses in 10 years, according to the Minnesota Department of Health, so we know that the demand for services is only increasing. We ask that you stand with us in affirming our clients' dignity by continuing to make these essential HIV services available to them. While the governor's budget marks about $6 million for HIV services, we know that more truly is needed right now. Though not enough to fully meet the needs of our community, the $9 million earmarked in the proposed budget could make a significant impact in ensuring our clients can continue accessing these vital services. Thank you for your time and your support.
Thank you very much. The last testifier I have on the list is Kat Roan. Welcome to the committee, and please state your name for the record and begin.
Thank you. My name is Kat Roan, and I serve as Executive Director of Outfront Minnesota, our state's largest LGBTQ+ advocacy organization. I come here today to testify in support of this bill and in support of critical HIV prevention investments here in Minnesota. Today is March 12th, and I think it's important that as we hold a hearing on this particular bill, that we recognize that on this day in 1987, ACT UP was founded. It's a reminder of the long and rich history of advocacy and activism that has ensured our community's voices are at the table on this and so many other issues. Much has changed since 1987 for the better. Much remains to be done. While our organization is not a direct recipient of HIV prevention funding, we know the critical impacts these funds have across the state here in Minnesota and the important role that they play in ensuring members of our LGBTQ+ communities and so many others across this state are supported, cared for, and protected as we all work towards a day when we can eliminate HIV in the state of Minnesota. Minnesota is in the midst of a continuing crisis of new HIV infections, and it's critical that we recognize that the work here is not done. HIV prevention work is not just a good thing to do, the right thing to do. It's a smart investment that will save our state money in the long run on productivity impacts, direct healthcare costs, and a whole host of ancillary services. We have seen that work in action across the multi-decade history of community and public health partnerships. These are good investments, important partnerships, and it's critical that we recommit ourselves to funding them fully as we seek to meet this moment. Unfortunately, we sit in a moment where commitments to public health are in a deep space of uncertainty. Now is not the time to wind down or limit support for critical work. Now is a critical time for Minnesota to continue to step up to address HIV in our state. We urge you to support this bill. Thank you.
Thank you very much. Members, any questions or comments about the bill? No? Senator Edke.
Thank you, Madam Chair. And I apologize if this was mentioned when you first introduced the bill, because I missed a little bit of it, but what is the current base? Where are we starting from with this?
Madam
Senator
Chair,
Dibble.
I knew that's what Senator Epke was going to ask, and I was hoping you wouldn't, because I don't actually know the answer to that question. I'm not sure what the total funding is in this area. So someone else, maybe one of the number guys, could help me.
Mr.
Madam
Bessel.
Chair and Senator Dibble, I also am not sure, though I don't think there are any state general fund dollars currently. I believe the money comes from a variety of other sources. And the program that you mentioned, the AIDS Drug Assistance Program, I believe is the one that has had changes and is leading to this $9 million or so deficiency in the funding level overall.
Senator Edke.
Thank you, Madam Chair. When the bill is short and to the point, but when it does propose to offer it through grants, and it just, to community-based support service providers, which is kind of wide open. And if I go back to the 24-20, I guess what was probably appropriated in 23, because it's listed as 24 and some of it's 24-25. There was where it was divided down to support services funding and then prevention health equity programming. So there's been a couple different items listed in the past. This one just saying support service providers seems to be kind of wide open. Is there more direction that could be given, or I guess help me understand that is to where what it all could be used for, and who would be the recipients, or who would be those applying for the grants?
Senator Dibble.
Thank you, Madam Chair. What this would propose is to simply, plug a $9 million hole in the existing budget that the Department of Human Services administers for the HIV Supports Division. So I don't anticipate that, it would change their criteria and their grant application program that they use, when they request folks to come in and propose, ways to spend these resources in community-based settings, such as Rural AIDS Action Network, Clare Housing, Open Arms Minnesota, Liveness Project, and a number of others that we have out there that are providing housing, food supports, case management services, and those sorts of things through nonprofit community-based organizations that serve people with HIV and people with AIDS. Does that make sense?
Senator Edke.
Thank you, Madam Chair. No, that's all. Thank you.
Any other questions or comments? Senator Curran.
Thank you, Madam Chair. And Senator Dibble, on this program or any other program, when we're moving it from what was a biennium budget process of seeking funding for an initiative, and then using the whole grants process, I think in this particular case, and I think in every case where we're looking to move something in or proposing into base funding, I think we should propose and we should get and walk away from the grant process, because the grant process in it by its very own nature is temporary. If it's a service we've determined that we need, I think we should move into if it's going to go in base funding, we should change the procurement method and how they're obtained, or how we procure for those services. One, we can seek longer term, certainly from a 2-year haphazard opportunity, right, from a certainties perspective into longer contracting, and then certainly getting, I believe that process will bring more control and oversight on the providers we choose or the companies we contract with instead of the grant programs, because as you know, we've seen continued challenges on grantees in compliance with good oversight for our dollars. In fact, the one area, and it's brought up here, in the Rural AIDS Action Network, right, their 2023 audit showed that they didn't get some approval or didn't have any documentation for 28 of some 40 expenditures with no documentation. We just can't have that. I don't care what the program is. And so I think we should be looking at what are those specific services and who should we procure them from, and then the delineation from, as the stated needs were in many other areas of housing support for which we have millions of dollars in all other programs for which people are eligible for. So if we're going to have specific things for specific initiatives, I think we should really consider choosing a different method, because grants, I don't think, is where we should go long-term at all for if what we've deemed any critical service that we're going to put into base funding. So,
Senator Dibble.
Thank you, Madam Chair. Good points. I don't disagree with them. You know, particularly if we're talking about continuing to provide those services through community-based organizations, like, you know, some of those represented, you know, with the due diligence that they're doing their work well and above board, you know, to all standards that we choose. We're on the audit commission together, so we understand what that all means. And I'm guessing that they would welcome, you know, a more stable fiscal environment in which to operate, you know, particularly in light of, you know, if we're to succeed at, you know, this is just, keep in mind, a budget hole of, you know, I think the answer to Senator Utke's question is around $30 million, if I understand that what was just handed to me a second ago. So it's hard for nonprofit organizations to kind of live and die, you know, by 2-year grant cycles, whether those grants are coming from foundations or coming from through government contracts, that level of instability. And, you know, sometimes when, you know, either a community or corporate or family foundation changes focus and direction, all of a sudden, you know, those funds get yanked. Likewise, there's some variability in administration of grants through government sources as well. And I was a nonprofit executive director, and I know what that feels like. So I hear you. So
Madam Chair,
I'm wide open to the conversation.
Madam Chair,
Senator
just a
Curran.
quick follow-up. Senator Dibble, and I don't care about whether nonprofit or otherwise, right? Because when we decide to go procure services, they're just businesses, and they're there to provide a service. And so, but the delineation between the grant process, which is typically then driven by those in the nonprofit sector, by the mere fact, if we choose to keep some of those in the long term, because we want to explore, right, and kind of examine how we can better serve and maybe get a little creativity to test something that would address those challenges, then, and that to me is temporary, as it has been, right, in that cycle. But then we move on to, we want to procure for those services, and how do we do it best to make sure we have a competitive nature to get the best product, and then we can hire and fire as needed, and I think it provides better oversight. So I appreciate it. Thank you.
Senator Dibble, any other further comments?
I have a few thoughts to add, but I'll
Okay.
carry on the conversation privately with Senator Curran, because
Sure.
I do agree with him in a lot of ways.
All right. Well, this bill for right now will be laid over so that we can have further discussions, or you can have further discussions. And if you see any need to refine the language, you can let us know. Senate File 1385 is laid over. And Senator Dibble, you have Senate File 1918.
Yes, Madam Chair, and as I understand, Senate File 1918 has just 2 sections that you wanted to confine this presentation and your discussion too, which are sections 15 and 16, is that correct?
Senate Council, I don't know if the specific sections that relate to our committee, is it only sections 15 and 16? Does that make, okay. So, yeah, we were hoping to kind of keep the discussion just to that narrow part because the bill needs to go to Human Services and has, much more of a relationship to discussions that go on in Human Services. Obviously, members, if you have a question or a comment about another part of the bill, I'm not forbidding that. I'm just hoping that as we can keep the discussion to the areas that are pertinent to our committee and move it along to the Human Services Committee. So Senator Dibble, if you wish to present your bill.
Thank you, Madam Chair and members. Appreciate the opportunity to present Senate File 1918, and I'll just invite Ms. Scheller forward to jump in as soon as I'm done, because I'll be very brief. Members can turn to those sections 15 and 16. They start at the top of page 13 of the bill, and they have to do with, this particular section has to do with the matter of visiting, allowing for folks who are in a long-term care setting to receive visitors. The concern is, and the problem trying to be solved, is when healthcare agents have the power and authority to prevent persons from visiting a patient or a resident, sometimes that decision is not in the best interest of the resident. There are examples of family members being denied visits, even at the end of life, because of an ill-informed or overzealous agent. The provider generally follows the direction of the healthcare agent, the provider being, of course, the facility. This action of blocking visitors is similar to a guardian doing the same, and we've heard a lot of discussion around guardianship in the legislature, and we have a whole task force that will be meeting for the next couple of years, and we have a report coming from the legislative auditor in a week or two. To address the concern as to guardianship, legislation was passed in that realm to establish thresholds for when a guardian may restrict visitation. Similar measures are proposed to be in place for healthcare agents. So you can see the language in front of you. It includes those thresholds of visitation in the healthcare directive statute, similar to those elements that are present for guardians. So that's the overview of the issue and the proposed solution. We have Susie Scheller here from Elder Voice Advocates, who has worked very hard in this realm with that organization and is in very, very close contact with folks who are living in these circumstances as well as their family, have a number of examples to share and develop this proposed solution. Thank you, Madam Chair.
Thank you, and welcome to the committee, and please state your name for the record, and you can begin.
Thank you so much, Chair Wickland, members of the committee. My name is Suzanne Scheller, and I am the legal advisor for Elder Voice Advocates, whose mission is to champion solutions that protect human right to quality long-term care for elders and vulnerable adults. And the first thing I want to note is that what we've brought before in a larger context here is coming out of many calls, emails, communications that we receive from residents or their families or those who are the part of the support system for those residents. So it is born out of those stories, not just one, but many. And so what we're bringing before you is the context in sections 15, 16, where you have someone in a long-term care situation, not an acute care situation or a temporary situation, but the healthcare agent under law has the presumption of acting in good faith. And if the healthcare agent is telling the assisted living or the nursing home or the home care agency that a particular individual should not be able to visit or call or have any communication with someone, and sometimes that is merited, but they are utilizing that agency power, we believe, to prevent the support system from being around that resident, which is critical. So we're talking about a long-term care situation, an ongoing restriction. And so we have had calls of of sisters in their 80s not being able to visit each other. One sister sending birthday cards not even being delivered to their loved one in the facility at the hands of someone saying, I restrict that visitation. The provider listens to that without more. And we have what we would consider an abuse of power, and sometimes this is used in retaliation to what's going on. If there's an advocate that's coming in to advocate for their loved one in the facility, sometimes this restriction by a healthcare agent who disagrees is one of those forms of retaliation. So we are seeing frequent concerns of not just visits, but calls and all communication occurring. And we believe that's not in the best interest of the resident, and we believe it is a form of retaliation that is occurring. So what this law does actually mirrors the guardianship statute that was changed in 2020 at 524.5-313, I think it's C6, and then also at 524.5.0120, that's the guardian bill of, person subject to guardianship bill of rights. So it's mirroring that language of the ability to restrict for good cause shown. So, and what this is intended to do is just disrupt that presumption that all of these communications from the agent are presumed to be in the best interests of the principal, but rather allow us to pause and say, allow the provider potentially to pause and say, is this in the best interest of the resident? Do we have some evidence that this is an abuse of the healthcare agent's power here? And so right now, because of the presumption, there is usually little challenge from the provider about these restrictions. So we're trying to give some pause to that and allow, in appropriate situations, the visitation or the communication to continue. And oftentimes, I will also note that there's alternatives being provided where there might be some level of concern, some visits with time limits or periodic limits, and we have been open to those discussions, but oftentimes the agency's power is trumping all of those possibilities to the detriment of the resident. So that's partly why we're here. It has two parts to it: introducing subdivision 6 about the need to show or need to have some basis for the restriction, which is identified as significant physical, psychological, or financial harm to the principal, which again is language the same language in the guardianship statute, and then the presumption under 145C.10, so that we have to have the presumption changing as it relates to the restriction. Hopefully that makes sense, and I'm certainly willing to answer any questions.
Members, do you have any questions? Senator Coran.
Thank you, Madam Chair. And so just reading through subdivision 6, because you used the healthcare agent, we've got principal, you used a sister, which had no delineation. We get that familiar relationship. And then you used legal advocate or guardian. And so who's the healthcare agent in this scenario? Is that the nursing home, the provider?
The healthcare agent is the
Ms.
one.
Schiller?
Oh, sorry, excuse me.
Ms. Schiller, please proceed.
Senator Cran, the healthcare agent is the individual appointed by the resident. So the principal would be the resident. They're appointing someone as an agent to operate in certain duties and powers over their healthcare decisions.
Thank you, Madam Chair.
Senator Cran.
Thank you, and Madam Chair. And so with that, it's going to be up to the facility where the client resides to oversee what their directives are, and how would they influence or enforce those things if they believe harm? We've got an ombudsman for elder care, we've got a whole host of Vulnerable Adult Protection Act, all of those things. How would they go about taking action when you list basically a determination in any aspect of their life, from social media to mail to otherwise? It seems like we have all of those things in place already. And then how will a nursing home or convalescent facility manage that? So it just, to me, it's not that clear. And so walking through the scenarios of the sister, right, that they're not getting the mail, that's a that doesn't seem to fit here unless they've been directed, if that person's their provider or the guardian, by a nursing home in some case. I'm still confused on how these scenarios fit and how this fixes it when we have a whole host of other services. If somebody's being, or we believe that the best interest of the person that resides there is not being managed by their guardian, and vice versa. For the guardian that doesn't believe the care is being provided well. And so this is kind of in a gray area that the nursing home then has to go and manage, social media, and that's not their role, or do they have the tools to do those things? So I'm just looking for more clear scenarios to understand what isn't already being covered by many different resources in this network, whether people are aware or not. But this is the nursing home overseeing and actions of a guardian and what they may or may not do when it seems to be appropriate or not appropriate, and then the alternatives. This seems like a heavy-handed approach that I'm not sure will fix it. So I'm just like nuts and bolts scenarios of how this, what the scenarios are that are broken, and then how this fixes it.
Ms. Scheller.
Yes, Senator Cran. What I'm trying to, you've asked for particular scenarios, and I don't believe that the one I gave is outside of the scope here. What I do want to make clear is, first of all, I only reference the guardian because it is existing language in law from which this concept is taken. So we leave that appointment aside because that is a court oversight appointment. A healthcare agent does not have any court oversight over that appointment. So to the point of this seems to already be taken care of in law, I would just note respectfully that, again, these are coming from concerns that are expressed. So what we have encountered is whether it's a spouse, whether it's a brother, whether it's even a friend, the agent has told the long-term care provider, this person is on the do not allow list. Right? This person cannot see, contact, et cetera. And to get on that do not allow list doesn't have any criteria at this moment. It's simply the direction of the healthcare agent saying so. Okay? So we have that concern of other avenues not accounting for that scenario of someone simply saying, I, as the agent, say no to that. To your point of
Madam Chair, if I could interject.
Senator Cran.
But did you, again, I'm trying to walk through this scenario. I'm sorry if I'm the only one confused, is in that scenario, you described that the healthcare agent initially, because it resided around guardianship or somebody that had the responsibility, but now you said that they didn't have any court-ordered authority. So this means, is this a doctor or somebody that's, because a healthcare agent, just when you opened up your scenario, I thought you said they didn't have any court-ordered authority, so they technically weren't a guardian. It's what I kind of heard. So then who is that? Who is that acting on their behalf in this agent role that's not court-ordered or a legal guardian?
Senator Cran, I think a healthcare agent is like, there, you can fill out a form and sign it and have witness, maybe witness it, and then you can choose a healthcare agent. And then there's some documentation, I think, that I've seen, like my parents have shown me, here's what we're filling out for our healthcare agent. So I think it's a standard thing, but it isn't a court, doesn't involve the courts.
So, Madam Chair, so it's a quasi-guardian, not a quasi-guardianship, but somebody, you've granted them the authority to act on your behalf. Okay. All right, thank you.
Ms. Schiller, I believe that, that's what I understand, that they are someone that you say can speak for you and can act in certain ways. And that's where you're running into they're acting in ways that are stricter maybe than what the person might want. Ms. Schiller.
Yes, I'll back up and talk about a healthcare directive. Just it is a document that is not a It's a document that any person can sign. It does two things. It appoints an agent or allows you to express your healthcare wishes. So you are signing that document, appointing an agent. It does not go anywhere in terms of oversight by the court. A guardian is appointed by the court with court oversight, and that's the distinction. This is a process, a healthcare directive is a process that is signed outside of any court process. So it is just, we're giving it to the provider, for instance, so they know who the appointed agent is, they know the healthcare wishes. And so that's a distinction. Okay, there's no oversight over that. Someone can have a healthcare directive and keep it in their drawer the entire life, and no one sees that. They've appointed an agent, but it's just not been, there's not communication of that. So we're talking about a process that is inherently intended to be a least restrictive alternative, intended to appoint a person to operate on your behalf, and at times we're experiencing that appointed agent making restrictions that may not be in the best interest of the principal.
Madam Chair.
Senator
thank you.
Graham.
Yeah, that helps. And we all know those dynamic scenarios. So that agent could be family, may not be, may be anybody. And of course, the most dire time in their life in the long term, especially when it comes to those healthcare decisions or directives. And the family dynamics, those accept it, those that don't, and the complex needs that the provider has in this case to be able to oversee and manage that, and who should they be taking direction from? But then that becomes kind of a civil matter, doesn't it? Was the person capable, or did they go against the direction of it's their favorite youngest child? All the dynamics of that person that is in that directive mode, whether it be guardianship and or a healthcare an agent. It seems like an awful a burden that still is then kind of civil from one perspective. Who's got rights, and did mom or dad or whoever's in there, were they right sound of mind when they collected that? And then the nursing home or the provider is going to be stuck in the middle, as they are every day, to manage the dynamics of everybody that cares about that loved one differently while they're in that care. So that helps a lot, but I think we have most of those things in place. So, but I don't see anybody at the table expressing opposition. So thank you, Madam Chair, and thank you, Senator Dibble.
Ms. Scheller.
I would just add one comment to the second part of the question about who manages this. This is very consistent with other areas of the law where we say good cause shown. We, in terms of the provider analysis here, we're not putting any requirement on the provider to assess the validity and or of the healthcare directive, et cetera. But what we are doing is we are putting some language around the healthcare agent's actions and duties, so that the healthcare agent is aware that they have a responsibility to operate in the best interests of the principal, and there has to be some cause for them to have some knowledge of harm that may occur. So it is intended language for the healthcare agent. Thank you.
Thank you. Any other member questions? Senator Abler.
Well, thank you, and I think we could spend the rest of the time talking about this. I don't think it's casual, but to the whole bill, I notice there's not a House companion. This conversation I've been a part of for a number of years, and the way the conversation ordinarily goes is there's quite a broad inclusion of various people. And Senator Dibble, thanks for bringing it forward. But just to remind you, on a topic like this, customarily you'd have an array of co-authors who are, on one side or the other in this thing that want to bring the topic forward. There would be lobbying that would have happened on behalf of elder voices, who I'm very friendly with in the past on things. And where there's concerns brought forward, I have a number of people that have had the very concern this section addresses. But it just seems kind of like premature. And so when we were discussing this legislation in our huddle, no one had ever heard of it. No one had talked to anybody about it. The concerns are relevant. The imperative actually strongly opposes this section. I'm not sure why they should, but as we craft this kind of a solution, it's usually just much more inclusive. And so, you know, I'll vote to move it along, but this is not settled. The issue is very great. And so Senator Wickland and others, you know, we hear from the caring daughter who doesn't get to go see her mom, and the sister is just not fair and just wants the money. And we go, oh, that's too bad, and send them to the ombudsman, and nothing happens. Call up the place, they go like, well, this person's really annoying, and they come and we think that they're dangerous, and so it's a mess, and so we never know what the truth is. We just know one side of the story, and so this attempts to open that up, which I think there's merit in that, but in the systems that we have, I think we need to listen to the voices of the operators as well and find a way to make this actually work. There is a problem. And the whole rest of the bill, which we'll discuss elsewhere, is similarly a proposal and expressions of concern by your group, and I respect that. But if you want this to actually change anything, there needs to be more discussion. And I would think that, I'm not sure if Senator Hoffman's been involved. I don't know if anybody, all the rest of our people, no one's talked to me. I've been heavily engaged in this. I remember when Senator Fischbach worked on this in the past, that there was a lot of inclusion. So not to take any more time, and I have many questions on this section, which I will not do any of. I know the time we have. But if you want this to happen, let's keep talking about it, broaden the discussion. And thank you, Senator Dibble, for bringing it forward. And I totally get your angle on it. So thank you, Madam Chair.
Senator Dibble, did you?
Thank you to Senator Abler, and that is my commitment to him, to do exactly what he advises.
Okay. Senator Edke.
Thank you, Madam Chair. Senator Dibble could probably help us with this so that it's on the record, but where did the bill come from? Who's promoting it? If we could get
Senator Dibble.
its origin.
Thank you. His origin is the work and the advocacy and the relationship that Elder Voice Advocates has with their constituency and folks that form and rely on that organization for advocacy and assistance.
Senator Edke.
Thank you, Madam Chair. I don't need anything repeated, but we're going to have you move a little closer to that mic.
Oh, sorry.
You're fading away on me. But
the short version is these
Senator
folks,
Dibble.
Elder Voice, sorry, Madam Chair, Elder Voice Advocates has developed this bill. I mean, there's a lot in it, as you see, and it's based on their experience, you know, on the front lines working with folks. I mean, Elder Voice Advocates is, you know, an accumulation of many, many, many people. They're the ones who first brought us all of the information and the stories that gave rise to the wholesale reform we did in assisted living and assisted living licensure. That was all sparked by the work of Elder Voice Advocates. So they're the ones who brought the stories and the anecdotes and have identified the problems and developed proposed solutions to those problems that people are experiencing in long-term care settings.
Senator Edke.
Thank you, Madam Chair. And I've shared this before, I think, with some of them, but I just look at this as it's additional threats and assaults on some of our nursing homes, and I believe the vast, vast majority are, I mean, there's saints out there doing great work. They run into instances here and there possibly, but, you know, I hope that we aren't further tying their hands and making their life harder as far as harder in the fact of who they're serving and trying to do the best job they can. One thing I do see in there that, you know, we've talked a lot about this healthcare agent, but it ends with acting in good faith. To me, again, how do we define good faith, and what is that doing to our healthcare provider in these facilities? Because is it, well, that was minor good faith, or it's, you know, major? And it's, I guess this can be more of a comment because we need to move on to, but those are some of my concerns that I have as I look at what, just a little section of this bill we're focusing on today.
Madam Chair.
Thank you.
Senator Dibble, and we do need to move on to the final bill we have.
I do want to respond just quickly to Senator Edke. I agree with you. My sister works in a nursing home. She's an LPN. She's a saint, a literal saint. So I completely agree with you. The folks who are working in our nursing homes work very, very hard and take care of our mothers and fathers and grandparents. This, has some language that's fairly legally construed. So when we say good faith, that has a very specific legal definition. So it's not good faith as we would think of it in regular parlance. It has a legal construction and good cause as well. So you pair good cause and good faith, and that points you to if, in fact, someone on good faith thinks that someone needs to be restricted from seeing another individual, then they just have to show it. They have to document their reasons and not just simply assert as such. And I agree, our nursing homes do great work, but I have a nursing home in my district that's been purchased by a private equity firm. No one knows who actually owns and operates, and they're running it now on a for-profit basis and making a lot of changes that aren't in the interest at the business level. The people working there are working very, very hard. They themselves feel very constrained and very frustrated with what they're being told to do by these for-profit owners from another state. We can't even figure out who they are. We know where the buck stops. And so we're trying to address some of that comes up systematically and systemically from those kinds of circumstances. Thank you, Madam Chair.
Senator Liskey, I'm sorry. Okay, Senator Liskey.
Thank you, Madam Chair, and I'll try and keep it as quick as possible. So I was reached out to by some veterans, actually. They were in veterans' homes, so not exactly what this bill is addressing, but they had a similar concern with some of the retaliation parts. So I just wanted to bring awareness to you that maybe we need to have that conversation separate from this bill specifically, but that is a discussion that I think we need to have more broadly, as is the concerns of retaliation. So just wanted to bring that to your awareness. Thank you.
Thank you.
Okay, members, any other comments or questions?
Madam Chair,
Senator
can
Abler.
we just move it without recommendations so this can keep being worked on? Thank you.
Yeah, that was going to suggest that, no, it's okay. No,
I'll let you
I
say
mean,
it,
I was.
Madam Chair, I'll withdraw my suggestion and wait for you.
Okay. I would suggest, Senator Dibble, we do find that, I mean, the small part does give us a lot of questions, and I think some of them need to be resolved in a more like a judiciary committee setting, because they're things that I don't think we can decide here, but I think it needs to go to Human Services to get the full discussion about all of the parts and the electronic monitoring and all of the other, I mean, collectively, the bill should be discussed there. So I guess I would recommend that we do pass it without recommendation. You know, you get the sense that people do have questions about it and would like to see you continue to work on it. So it's harder for us to support at this time. So members, Senator Abler moves that Senate File 1918 be recommended to pass without recommendation to the Committee on Human Services. All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 1918 is recommended to pass without recommendation to the Committee on Human Services.
Thank you, Madam Chair and members.
Thank you. Now we are going to move to Senate File 856. Members, we do have a number of amendments to discuss about or related to this bill. I would ask that, Senator Gustafson, if you can give us the high-level overview of the bill and, your opening comments, and keep it as streamlined as possible. And then I believe there's one amendment that you have that is more general things that we could discuss. And then I can move to the amendment that I've worked on with others, and we can discuss that. And then we do have one testifier, is that correct? From the public. So if you could do your high-level overview, if we can get the brief testimony from the member of the public, and then we'll move to your first amendment. Senator Gustafson.
Thank you, Madam Chair. And a big thank you to this committee who I've met with, I believe all of you, or either briefly or extensively, and I just want to say thank you so much for working with me on this. It's appreciated. Also want to reach out to my co-authors and workers, and for joining me on this bill. Senator Draheim is also joining me here to co-present this bill. I'm very grateful for the work that he has put into this bill with me, as well as Senator Putnam, Senator Crewin, and Senator Latz. So Chair and members of the committee, thank you for the opportunity to present 856. It establishes the Office of Inspector General to strengthen accountability, transparency, and oversight of our public dollars. The bill is a proactive step to protect public funds, prevent fraud and misuse, and improve government efficiency while ensuring that existing agencies retain their essential program integrity functions. Through extensive stakeholder feedback, including from this committee, we have refined SF 856 to address concerns about jurisdictional clarity, data confidentiality, and interagency coordination. The bill excludes the OIG from Medicaid fraud investigations, child care licensing, and other compliance functions that must remain within the Department of Human Services and the Department of Children, Youth, and Family. Instead, the OIG will focus on system-wide fraud prevention while working collaboratively with these agencies through clear interagency agreements. The bill is not about duplication. It is about enhancing oversight while ensuring efficiency. It establishes a framework for effective cooperation, defines confidentiality protections, and ensures that investigations do not get lost in bureaucratic silos. It also includes provisions to resolve jurisdictional disputes efficiently and ensure that investigations are handled appropriately without overreach. I look forward to discussing this bill and working with partners to ensure we create a system that protects public resources, improves accountability, and upholds the integrity of our state programs. And thank you, Madam Chair. I think Senator Draheim has a brief statement too, if you're okay with that.
Senator Draheim.
Thank you, Chair Wickland, and thank you, committee members. We have been meeting on Tuesday nights with a bipartisan group, and both with the House and Senate and nonpartisan staff, trying to iron out the details. And it's a very fluid bill, and we are trying really hard to make it kind of an even playing field where it's not political. It does not favor the legislative body or the executive body, just an agency that can do its job. And we have the term of the Inspector General at 5 years, so it doesn't get influenced by elections. And there are a couple other ideas out there and some other bills, and those members that are on those other bills are meeting with us too. So if any of you are interested in spending your Tuesday night with us, we usually meet at 5 o'clock. Everybody is welcome. It is truly one of the most bipartisan groups that I've been part of in the 9 years I've been here. So I thank Senator Gustafson for leading the charge.
Thank you. Then why don't we have one member of the public who signed up to testify, Omar Jamal. Is he here? I don't see him present. Not online. Okay. Okay. Well, then we will move forward. Senator Gustafson, you had the A32 amendment, and I don't know if you've spoken with someone on the committee. Senator Mann offers the A32 amendment, and that has been posted online. If you could talk to us about what those changes are and where they came from. Thank you.
Yes, thank you, Madam Chair. So the 832 amendment refines the bill's language, making investigations broader by including failure to act, redefining abuse as misuse. The amendment removes the word abuse and replaces it with misuse in multiple places. We felt like that was just a better phrase for what an OIG would be doing. The amendment adds the formal definition. It also adds or failure to act and investigation criteria, and then it deletes some budget language but adds a new section explicitly stating that funding will be appropriated for the creation of the OIG.
Members, do you have any questions about the A32 amendment? questions. I noticed that, one of the duties was removed, that I just wanted to find out, did that come from work that you had been doing on this joint committee discussion? The duty number 5. On page, I'm sorry, lines 5.11 through 5.14.
Thank you, Madam Chair, as I go through a pile of paper here.
Yeah,
Just
sorry.
Give me a moment. I'm sorry, and can you give me the page and line again?
5.11 to 14 are being deleted. And I just wondered if that was where that work was done to decide that duty would be removed.
Chair, if I could.
Senator Dereham.
Thank you. I think that has to do with the constitutionality of the bill, and a lot of that will depend on, Senator Cruin's been working on that very closely. But I think that is what we were trying to establish there. And it's, correct me if I'm wrong, but that's why it was removed.
Okay. Thank you. Any other member questions? Okay, we'll move forward. Senator Mann moves the A32 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Gustafson, now I guess I would like to discuss and bring up, move the A30 amendment. As we knew the bill was coming to our committee, I and my staff and others, nonpartisan staff, we had some concerns about some of the duties of the Inspector General and not wanting to see that functions that go on in the Department of Human Services and the Department of Children, Youth, and Families, that some of the work that they do that interacts with the federal government, that we didn't want to see risks due to a lack of compliance and impacts to federal funding or federal requirements for investigations. We didn't see, or we saw that there needed to be a little more clarity about who had responsibility for different functions, and a process also for working out concerns over time. And Senator Gustafson mentioned some of this in her opening remarks as well. So basically the A30 amendment, the powers and duties section is left as it was. It does add in subdivision 2 exceptions for DHS with respect to Medicaid and for DCYF with respect to the CCAP program, and also excludes work that they do that has to do with general compliance reviews and IT security audits, that type of thing that aren't related to fraud or abuse, explicitly stating that the OIG would not have jurisdiction over those functions. And then we wanted to make it clear that if there are tips that come in or information comes in to the new Inspector General, that gets handed off to the appropriate agency if it relates to one of these functions that we explicitly call out that they don't have jurisdiction over. So it's to make sure that those get handed off. The next lines, 2.18 through 2.28, had to do with the data sharing and just allowing the OIG to share data with DHS and DCYF. It just adds another statement that makes that explicit and clarifies the status of data as being private data. We worked on this section of the amendment with the counsel from Judiciary as well. And then starting on 2.29, it adds to different, it adds to the area where specific functions are delineated as being excluded from moving. And so it further delineates some exceptions to moving to the new OIG. And that was because we wanted to make it clear about Medicaid, Minnesota Care, and then also the divisions within Department of Children, Youth, and Families that we did not think should transfer. I think that this is complete, but we will continue to have discussions. I think the agencies need to provide more feedback on that part of the language. And then, as Senator Gustafson mentioned, that we felt that there were some situations that might come up that we couldn't account for all of them in the bill language, but that by proposing an interagency agreement be developed, especially to handle potential similar or duplicative investigations, we thought that that would be a way that we could make sure those things get discussed, including, how cost sharing would happen, or just all of the details of a process that would need to be worked out pertaining to investigations. But we also, the bill author wanted to make sure that the OIG has the ability to investigate the departments. So it doesn't limit the authority to any investigation of the Department of Human Services or Children, Youth, and Families. We received feedback in the letter that's posted from DHS about concerns about the interagency agreement language, and so I think, Senator Gustafson, I think that you'll need to continue to work with them. We didn't want to, or we didn't intend that this would introduce any lack of clarity, so if there's a way to add additional language to it to make sure it's clear that we're talking about potential similar or duplicative investigations that aren't already addressed through the bill language, that might be a way to help clarify for the agency that that's the intent. But I think it'd be good to work with DHS about that concern that they raised in the letter. And then the last page, page 4, 4.1 to 4.12, it just clarifies that DHS and DCYF must share reports with the Office of the Inspector General. And then the last lines, 4.13 through 4.16, clarifies that there are other exemptions added in this amendment to the exclusions from transferring. So we wanted that needed to carry through. I think with Article 2, Section 1, I'm not sure that we have fully defined yet how, or clearly enough, the entities that are transferring versus not transferring, but we worked with you to try and make sure that we made that progress forward in terms of defining it. But I would say we would like to see more definition. We just want to make sure that everybody is very clear about exactly who's being transferred and who is not. So that's the A30 amendment. And we have, oh. Okay, so we have a technical amendment to the A30, that's the A35, which, has that been handed out or not? They will pass that out right now. So the A35, oh, excuse me, Senator Abler.
Well, I have to go, but I just wanted to just offer one comment. People think this is what we do all the time, that we actually work together and in a collaborative way to solve a problem that's really on our minds. So I just want to thank you and the other, Senator Gustafson and Draheim and others who are putting this together. So it's just good to see. Thank you, Madam Chair.
Thank you. So I'd like to move the A35 amendment, and I don't know, Senate Council, if there's any more to say about it, but
Madam Chair?
Ms. Huffman-Litchi.
Madam Chair, had we moved the A30?
Yes.
But the
moved
35 is an amendment
30.
to the 30, right? So
Correct.
we'd have to move the 30 first?
Yes, I believe I said I moved the A30 amendment, but yes. Ms. Huffman-Litchi, did you have a comment about the A35?
Madam Chair, members, this is just to conform with what we already adopted in the A32. It conforms with lines 1.10 to 1.13 of the A32. It was easier for engrossing purposes to delete the section 6 and reinsert instead of adding like subdivision and subdivision. It's just easier for process. So those changes are just reflected in this A35.
Any questions about the A35? Then, will all those in favor of the moving the A35 amendment, please signify by saying aye. Aye. Any opposed? The A35 amendment to the A30 amendment is adopted. Now, back to the A30, we have an A36 amendment. The A36 amendment addresses a concern that was brought forward by the Department of Health. We hadn't considered or discussed the Department of Health as we were having our conversations over the last week, but they have brought forward a concern about the WIC program being another program that has federal implications that they need to maintain authority over within their department. And so the A36 amendment would add the WIC program to the excluded programs. And I believe, is that one being passed out? Oh, that one you should have, but I don't. Oh, we need to have it passed out. Ms. Hoffman-Litchi.
Hi, Madam Chair, members of the committee. The A36 is the exact same language that's in the A33 that was already in your packets, except for the fact that the A33 was drafted inadvertently to the A28, which was a previous version of the A30. Very confusing. Thank you.
Thank you. So members, I'd like to move the A36 amendment to the A30 amendment. Do you have any questions about that? Senator Coran.
Thank you, Madam Chair. And it kind of goes along with the whole piece of the. It appears to be a carve out on the original A30 for DCYF and DHS functions that are kind of required by federal law, and so our conversations have been around kind of operations and the functions that must remain in those agencies, especially those that have a specific federal requirement. They just happen to reside in an office called IG within the agency today, but it appears in all of our research, it shows that it should be, that it is really about those functions. It doesn't delineate the operational functions, compliance, licensing, oversight. That's still an agency responsibility. And then the delineation when it moves into an abuse or misuse or into a criminal investigation. In 30 for DHS and DCYF, you have then the exclusion, yet the secondary statement at the end of, on the interagency agreements that then says, yeah, let's just have really clear delineation of roles and responsibilities, what jobs, what capabilities, without limiting the investigative capabilities of the now independent Inspector General. So that, I think that makes sense. I don't know what conversations you had with the chair. I assume that, or I'm sorry, with Senator Gustafson. But I don't see that same, or I guess my question is then on the WIC program, in our research earlier, we didn't see that there was a federal requirement that that it must remain or that it has the similar jurisdictional requirements from a federal perspective. And if it does, then it would match the others, but we're missing the interagency requirement or that piece of it. To me, that would make it would be more understandable. But first, is there a federal requirement that under, similar to the DHS, that these functions remain under the WIC program, Department of Health?
Yes, that's Senator Cran, that is what we were told by the Department of Health. I don't know if they are here, or Autumn is here. Ms. Baum, I don't know if there's more to say about that, but that was what we were provided, the information that it is a federal requirement that they maintain control over that.
Madam Chair, then why was an interagency agreement not included in this similar to the other two?
Purely because this came last night to our attention, and so we didn't discuss it when we were discussing the interagency agreement. I don't think there'd be an objection to adding a section like that. Ms. Hoffman-Litchie, do you have a comment?
Madam Chair, members, no objection as nonpartisan staff. I think it was just missed because of the late breaking information.
Senator Cran, we spent most of our time over the past week when the bill was referred to our jurisdiction next. We spent the most time talking about DHS and DCYF. We just didn't have the information from MDH until a couple days ago, and then last night that we could create the amendment. But I mean, we can work on language that Senator Gustafson.
Thanks, Madam Chair. I think that's we need to do. I assume Senator Gustafson agreed with the original amendment, and then so we just need to follow up with the same, mirror the same statement for the interagency agreement or include Department of Health. Thank you. That's all my other comments.
Okay. And Senator Gustafson?
Madam Chair, this has to make a final stop at state local gov. We can always add that in there at that time, knowing that there's probably a couple of other agencies that will also may have some concerns or that we'll need to address. So if Senator Cran, who also sits on state local gov and will make sure to keep it all accountable, we could add that in there at that moment.
Thank you. Yeah, I think that would be helpful. And then you can also work on just whether it's formed correctly, the paragraphs we have. We did the best we could, but I think that they would benefit from discussion with the agencies. So members, any other questions about the A36 amendment? Then all those in favor of the A36 amendment to the A30 amendment, please signify by saying aye. Aye. Any opposed? The amendment is adopted. And now back to the A30 amendment as amended. Is there any further discussion or questions about that? Seeing none, all those in favor of the A30 amendment as amended, please signify by saying aye. Aye. Any opposed? The amendment is adopted. And now, Senator Gustafson, we're back to your bill. Is there any general discussion or questions about the bill? Okay, I don't see any. Thank you, Senator Gustafson, for your work this week with us. This is a really detail-oriented area or committee, and we try to make sure that we keep a kind of go over the bills and make sure that we are thinking that we've covered as much as we could in terms of the HHS jurisdiction. As you mentioned, it has other stops. If come across other things that I have questions about, I'll be happy to work with you on those if they come up. And I think I appreciate your openness to making sure that we do preserve agencies, federal, duties that they need to keep performing. And I hope that we can continue to talk about making sure that all of this is very clear to agencies and to the public as to who has responsibilities for what. So with that, I see no other questions or comments. Members, we will take a vote. Senator Mann moves that Senate File 856 as amended be recommended to pass and be referred to the Committee on Human Services. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 856 as amended is passed and referred to the Committee on Human Services.
Thank you.
Thank you. And seeing no other business on our agenda, we are adjourned.